Hello and welcome back to the channel. I hope that everybody is doing well, enjoying this holiday season. I cannot believe how fast time is going and that we are quickly approaching 2022. That is just absolutely crazy to think about if you ask me. So for today's video, I thought I would discuss managing asymptomatic but severely hypertensive patients. This means that the patient has a systolic greater than 180 or a diastolic greater than 120. However, the patient does not have any symptoms or perhaps only a mild headache, but no signs of acute end organ damage. I've actually honestly seen this a lot in many different settings as a nurse, and now working as a nurse practitioner, I'm seeing this in patients that I'm treating at the urgent care. Whether the patients are actually visiting the urgent care for their high blood pressure or it's found incidentally while taking their vital signs. But this is a patient that otherwise is sitting there comfortably talking with you, no complaints of chest pain, blurred vision, no numbness, tingling, nothing. But their blood pressure is severely elevated. So the question is, what do we do with these patients? Do they go straight to the emergency room? Do we try and lower their pressure in the outpatient setting? Or are they safe to go home and follow up with their primary care provider? I've seen patients given clonidine in the office to lower their systolic below some arbitrary number. I've seen patients sent to the emergency room, and then I've seen some discharged home without lowering their blood pressure with anything, and then just strict instructions to follow up with their PCP. So, which is the right course? Is there a right course? And well, you know me, I always want to know what the literature says and what the science says. So, hopefully, we can get down to that today. All right, so hypertension. This is a condition which causes the force of the blood pressure against a person's vessels to be too high. Severe hypertension, as I said, is defined as a systolic greater than 180 and a diastolic greater than 120. And with blood pressures this high, a variety of life-threatening conditions can occur, including hypertensive encephalopathy, or that's damage to the brain, retinal hemorrhages, papilledema, or pressure on the brain that causes swelling of the optic disc, or an acute kidney injury. Severe asymptomatic hypertension is also referred to hypertensive urgency, and most often it occurs with patients who have been non-compliant with their hypertension medications or their low sodium diet that they're supposed to be adhering to. As with any abnormal vital sign, said vital sign should be repeated, making sure to use proper technique and equipment. Also making sure that the patient is in a quiet environment, as this can actually decrease the systolic by 10 to 20 points. The most vital component of assessing a patient with severe hypertension is to evaluate for acute end organ damage, as this is classified as a hypertensive emergency, a true emergency, instead of hypertensive urgency because it requires immediate action on your part. So how can we evaluate first for this organ damage? First, doing our history and physical of the patient with hypertension, we should assess for the following red flags. And this also applies to patients with a blood pressure less than 180 or diastolic of 120 as well. So things like an acute head injury or trauma, generalized or focal neurologic symptoms or deficits, flame hemorrhages, cotton wool spots, or papilledema on fundoscopy, nausea and vomiting, as this can be signs of increased cranial pressure, chest pain, as this can indicate myocardial infarction or an aortic dissection, acute severe back pain, as this can also be concerning for an aortic dissection, dyspnea, shortness of breath, as this is concerning for pulmonary edema. And then if the patient is pregnant, then of course we're going to be concerned for preeclampsia and even eclampsia. If any of these are present, then our level of concern should be significantly higher, and then our threshold, of course, for an ER transfer is going to be much lower. In addition to this information that we gather during our H&P, tests that can help us to evaluate for end organ damage include, of course, the ECG, a chest x-ray, a urinalysis, serum electrolytes and creatinine, cardiac biomarkers, and this is if acute coronary syndrome, of course, is suspected, a CT or MRI of the brain if the patient had a head injury or is having neurological symptoms, retinopathy, or if nausea and vomiting are present, or a CT or MRI of the chest if there is a concern for aortic dissection. And now, of course, in the outpatient setting, not all of these are going to obviously be available to you. So I think it's clear that if this is a patient that you think cardiac biomarkers, a CT or an MRI of the brain or of the chest, those are indicated, then a referral to the emergency room is absolutely appropriate and indicated. All right, so back to our patient who is asymptomatic but severely hypertensive and without signs of acute organ damage, as this is actually the more common occurrence of the two. And what does the literature say for us to do for these patients? Well, unfortunately, the literature is limited and the optimal management of these patients is still unclear. So the question is, should we lower the blood pressure? What should the blood pressure be lowered to? And then how quickly should the blood pressure be lowered? Severely high blood pressure should be lowered over a period of hours to days. And it's a really close balance of weighing the risk of the following: either the risk of a stroke, MI, or kidney injury due to lowering a person's blood pressure too rapidly, and then the body's inability to then auto-regulate and maintain adequate tissue perfusion, versus the risk of an imminent cardiac or cerebral event that can, of course, occur from severe hypertension. So the general rule that I found on UpToDate was that the blood pressure should be generally reduced to less than 160 systolic and less than 100 diastolic. However, the mean arterial pressure should not be lowered by more than 25 to 30% over the first 2 to 4 hours. And therefore, of course, if you think about it, those patients with extremely high blood pressures, they may need to have their blood pressure lowered over days even to maintain that rule of not dropping their MAP too rapidly. UpToDate states that there is no proven benefit from rapid reduction of severe asymptomatic hypertension, and they offer 2 retrospective studies to support their claim. So in one study, there were 59,535 patients with severe asymptomatic hypertension who presented to an outpatient clinic. And the study found that there was no benefit from sending these patients to the ER versus managing them outpatient. At 6 months, the rate of cardiac event were 9% in both groups, and the rates of hospital admission within 30 days was actually lower in the group that was managed outpatient. And that was 48% compared to 59%. Another study that is included had 1,016 patients. They were treated in the ER for their severe asymptomatic hypertension. Of those patients, 435 of them received treatment to lower their blood pressure, whereas 581 were not given medication to lower their blood pressure. And in both groups, there was no difference in hospital admission at 30 days or differences in mortality. There were no differences, in mortality at 30 days and 1 year. On the contrary, rapid reduction of blood pressure can actually induce cerebral or myocardial ischemia or infarction or an acute kidney injury. If that blood pressure falls below the range at which tissue perfusion can be maintained by auto-regulation. And the elderly, they're at an even increased risk for cerebral or myocardial ischemia if the blood pressure is lowered excessively and or too rapidly. In these patients, the initial goal blood pressure may need to be achieved even more slowly, for example, over a week or even longer. So back to our patient. If it's determined that the blood pressure should be reduced more rapidly due to a risk of imminent damage or death, I think it's clear that these patients should be sent to the hospital. For those patients who do not require this rapid lowering of their blood pressure, it seems that blood pressure reduction over a period of days is going to be appropriate and safely managed in the outpatient setting. In patients who have been treated for their hypertension in the past, there are a few options. For example, restarting their previous medication, increasing the dose of their current blood pressure medication that they are on, adding another blood pressure agent, or adding a diuretic if kidney function permits. In those patients who have not been treated for hypertension in the past, who present with severe asymptomatic hypertension, UpToDate recommends starting these patients on 2 agents. They recommend a calcium channel blocker plus either an ACE or an ARB, and a close follow-up with their primary care in the following 1 to 2 days. Up to Date really emphasizes close follow-up with the primary care, and if the patient does not have a primary care provider, then determining where they can establish one before they are discharged home. 2 agents are recommended because oftentimes with initial therapy, a single blood pressure medication is unlikely to reduce the blood pressure sufficiently in those patients with the blood pressure more than 20 systolic or 10 diastolic above goal. I definitely like clear guidelines for best practice, but I know that that is not always realistic in medicine. Treatment plans, they often need to be tailored to the individual person based on their health history and specific risk factors. In scenarios such as these, where I have had a severely hypertensive, asymptomatic patient, I make sure to evaluate for all those red flags that I listed before, including a head injury, neurologic symptoms, acute retinopathy, nausea, vomiting, chest pain, severe acute back pain, dyspnea, shortness of breath, pregnancy. I assess for all of those. And then additionally, of course, those tests previously mentioned to evaluate for end organ damage. However, obviously, again, like I said, if there's any concern for something that requires something like cardiac biomarkers, CT, MRI, proper management would include a referral to the emergency department. Based on my understanding of the literature, I do not use agents such as clonidine to lower the patient's blood pressure in the office. And in those circumstances I have been in, each time it's been with a patient who has been non-compliant with their blood pressure medications, and thus I start them back on their hypertension medication with strict follow-up with their primary care within the next 48 hours, or return to clinic. I also always make a point to educate my patients on symptoms to be observant for, and for those that would require them to call 911 or go to the nearest ER. All right. Whew. So what do you guys think about this? How do you manage asymptomatic severely hypertensive patients? Or what have you seen done in practice? Let me know in the comments below. I'm really interested to hear what you guys have to say. Otherwise, I hope you enjoyed today's discussion and that it will be helpful for you in your practice. Remember, the overarching theme of practicing medicine is always going to be to assess the risk and benefit of each choice you make during treatment. Don't forget to like the video, subscribe to the channel. It's a free way to show your support and help me to continue making more videos like this one. And as always, I wish you all nothing but the best. Don't forget to learn something new every day. And until next time, I'll talk to you soon.